So we'll move on to drug interactions. And again, it's another common question when presenting to physicians and nurse practitioners. So a couple things we need to know right out of the gate would be that cannabinoids are oxidized, metabolized by the CYP system of the liver. So 2C9, 2C19, 3A4 of note. And also that CBD can actually inhibit some of those enzymes. So there's potential for drug-to-drug interactions. Clinically, we don't really see that at these low doses. The one documented drug interaction in the literature is a medication called clobazam that we typically don't use really that much. It's an anti-epileptic medication, but that would be something to note. If a patient was on clobazam, high doses of CBD can lead to increased sedation, so you would simply need to lower the dose. Because CBD inhibits 2C9, I've seen clinically patients that are on warfarin or Coumadin, you may see an INR tick up because it's inhibiting the breakdown of that, so you may need to adjust the dose accordingly to get their INR back to a normal level where you want it. So that's one of the clinical pearls. A common question I'm asked too on the anticoagulant side of things would be the NOACs or the DOACs. And again, there's a theoretical risk there because of the inhibition of the enzymes that break down those medications. But where we saw the interaction with clobazam was in the epilepsy trials. So again, think thousands of milligrams of CBD. Generally, we're using these low doses, and these theoretical drug-to-drug interactions simply we don't see. But what do I do in my patients on NOACs or DOACs? I'll screen for spontaneous bleeding, document that, make sure there's no episodes of that, and then we'll proceed with treatment. But those are some areas and interactions you should be aware of. But again, typically very well tolerated. And again, in long-term care, we have a number of patients on 10, 11 medications that are doing just fine using cannabinoids.